Thank you, Adriana, and thanks to the organizers for inviting me to this meeting. And so my talk is based on precursor disorders in myeloma, if we can potentially cure some of them. And you can see here my disclosures form. And you know that the main precursors of multiple myeloma are especially monoclonal gammopathy, as well as smoldering multiple myeloma. And also you know that the main difference, especially between MGUS and smoldering and active multiple myeloma, is the absence of myeloma-defining events for monoclonal gammopathy and smoldering multiple myeloma. And on the other side, we also know that myeloma is always preceded by monoclonal gammopathy and or smoldering. And we know that in our clinical practice, what we do is to treat patients when they achieve active myeloma at this point. But what we can potentially propose is to early treat myeloma. Why? Because active myeloma means the presence of this symptomatology: bone pain, usually in back and ribs, broken bones, infections, fever, anemia, renal impairment. So if we go to the oncology perspective, we know that the early treatment is something required for almost all solid tumors in order to achieve an eradication of the tumor, or at least to delay the progression to an active tumor. And in fact, you can see here the outcome from a polypus to colon cancer. And I would ask you, would you consider appropriate to wait until the colon cancer resulted in liver involvement to plan active treatment? Maybe the answer is no, and this is what we potentially plan for the precursors stage of myeloma. In fact, when we evaluate the outcome or the transition from MGUS to smoldering and myeloma from the biological point of view, you have to know that all myeloma clones are preceded by corresponding precursor states, and in fact, most genomic complexity is already present at MGUS status. The problem is that these clones, usually they don't all take the same road. So we need something else to progress from MGUS to smoldering and to active myeloma. And maybe this transition is going to be driven by the bone marrow microenvironment, as well as the immune system, bone cells, etc. But anyway, we know that the transition is not something uniform, and in fact we have in our clinic patients with MGUS or patients with smoldering that they will never progress to multiple myeloma. When we focus on monoclonal gammopathy, you know that it's a very frequent disease, and in fact approximately 5% of the population older than 70 years can potentially develop a monoclonal gammopathy. And in addition, we know that the risk of progression to myeloma is really very low, 1% per year, and in fact is an uniform risk. So I would like to plant this question: does it make sense to try to cure patients with monoclonal gammopathy? And from my personal point of view, and we can discuss later if you want, I don't think so. Because of the low risk of progression to myeloma, because of the median age at the moment of diagnosis, over 65, over 70 years, because of the high incidence and prevalence, so many patients would be maybe over-treated, and especially because there is not any evidence. And really, we would need many years, a lot of years, to prove the benefit, so the death of other reasons was going to compete with the primary endpoint, overall survival benefit. And so honestly, I think that it doesn't matter to treat patients with MGUS in order to try to cure them. However, what about other M protein related disorders that they are like MGUS but with clinical significance? In this case, I don't know if we are going to be able to cure these patients or not, but my clear recommendation that in case of M protein related disorders, and these related disorders can affect to the kidney, nervous, skin, coagulation, eyes, etc. In this case, if there is a causal relationship proven or highly reasonably suspected, please do treat these patients because they are going to get a benefit, although I don't know if they will be cured or not. However, when we evaluate smoldering is different because it's really a heterogeneous disease, and the risk of progression to myeloma is not uniform, as we previously seen for patients with monoclonal gammopathy. And we can identify patients at low risk, patients at intermediate risk, and patients at high risk. So I think that what we have to do is to try to identify the risk of progression to myeloma for each patient with smoldering, and we will see if we can potentially plan a cure for a specific subgroup of smoldering myeloma. And when we do a review of the literature, we can see that some trials were conducted in the past in smoldering myeloma in order to try, I don't know if to cure, but at least to try to delay the progression to myeloma. But there was not any benefit in terms of time to progression, in terms of overall survival. But the main reason was that low risk, intermediate risk, and high risk patients with smoldering myeloma were included in this trial. So I think that we have to focus on patients maybe with high risk progression to myeloma. And how can we identify this high risk group of patients with smoldering myeloma? We can use the major risk model, and we know that when smoldering myeloma patients have more than 3 grams and more than 10% of the plasma cell, the risk of progression to myeloma is 50% at 2 years. And also we know that when most of the plasma cells in the bone marrow compartment are clonal, are abnormal, are phenotypically aberrant, together with immunoparesia, again, the time to progression to myeloma is approximately 2 years. But also we know that when we evaluate the pattern of evolution of the monoclonal component and the N component increases over the time to progression to myeloma is also significantly higher. And in fact, so this model has been recently validated by the Mayo Clinic group using the evolving pattern for the monoclonal component together with the evolving pattern for hemoglobin. And when the M component increases and the hemoglobin decreases at least 0.5 grams per deciliter within the first year, together with a plasma cell bone marrow infiltration higher than 20%, the risk of progression to myeloma is going to be significantly higher. We can also consider high-risk cytogenetic abnormalities to identify patients at high risk of progression to myeloma, or why not the use of PET-CT. And when the PET is positive, the CT part is negative, we have to know that the risk of progression to myeloma and maybe to the development of a bone disease is going to be significantly higher. And with these different models, so we are going to identify a subgroup of high-risk smoldering myeloma patients in which the risk of progression is approximately 50% at 2 years. Can we potentially plan a cure for these patients? Or maybe the myeloma scientific community asked first, why not to try to identify ultra-high-risk smoldering myeloma, so those in which the risk of progression is not 50% at 2 years, but 70 or 80%. And this was done, and this was the rationale for the new criteria for the definition of myeloma, in which you know that when there is not any CRAB symptomatology, but any one of more of these biomarkers are present, clonal plasma cell higher than 60%, serum free light chain ratio higher than 100, or more than one focal lesion in MRI. In this situation, these patients should be called myeloma, and they have to be treated as myeloma. But what we are going to do when we treat as myeloma to these patients is to plan already an early treatment. And what we have to do is to evaluate in a prospective way if the outcome of these patients is going to be better than the active myeloma. And so I think that this is something that we will see in the future when the new clinical trials and also our clinical activity include more and more patients like this ultra-high risk smoldering myeloma that now they have to be considered as myeloma. What happens with the rest of high-risk smoldering myeloma? Can we potentially plan a cure for them, and so this is the rationale for the clinical trials that have been conducted and are being conducted in order to try either to delay the disease progression or maybe to cure some patients. And the first trial was the Curative study conducted by the Spanish myeloma group in high-risk smoldering myeloma with lenalidomide and dexamethasone versus observation. And lenalidomide and dexamethasone had just been approved for the treatment of relapsed and refractory myeloma patients, and we had the information about the efficacy and also about the safety, and this was the reason why we selected this combination as experimental arm. And we had the opportunity to see first how lenalidomide and dexamethasone worked in high-risk smoldering myeloma, and the overall response rate was even higher than the overall response rate reported in relapsed and refractory myeloma patients. But our primary endpoint was, of course, to evaluate the time to progression to myeloma, and with a median follow-up of 40 and with median follow-up of more than 6 years, you can see like the early treatment with lenalidomide and dexamethasone resulted into a significant delay in the time to progression to myeloma. And this primary endpoint was relevant, but what was really much more important was the benefit in terms of overall survival. That this benefit was observed just at the beginning when the median follow-up was approximately 3 years, and with a longer follow-up you can see like the benefit in overall survival is sustained. Safety profile was acceptable for this combination, and in fact patients developed very few grade 3-4 adverse events. So with this clinical trial, I think that the Curative trial was the starting point for a lot of clinical trials, more than 50 clinical trials that are currently ongoing for the early treatment for high-risk smoldering myeloma. And it's true that most of them, the main objective is to try to delay the progression to myeloma. But there are, at this moment, a couple of trials in which the objective of the early treatment for high-risk smoldering myeloma is the potential cure. Ilotuzumab is being added to lenalidomide and dexamethasone in this phase 2 study conducted in high-risk smoldering myeloma. Good results, but we need a longer follow-up to know the outcome in terms of time to progression to myeloma. Carfilzomib in combination with lenalidomide and dexamethasone, a small number of patients, but very effective in high-risk smoldering myeloma patients, even higher overall response rate and complete response rate than the same combination used in newly diagnosed patients with multiple myeloma. And daratumumab, CD38 monoclonal antibody, widely discussed in the previous session this morning, but it has been also evaluated in high-risk smoldering myeloma. Preliminary results seem to be positive, and in fact, a phase 3 trial is currently ongoing comparing daratumumab single agent versus observation in high-risk smoldering myeloma patients. And concerning the curative options, as I previously said, there are a couple of approaches. The first one is being done by the Spanish myeloma group, because so we established previously that the early treatment with Lendex was positive, so why not to try to move forward and to try to cure high-risk smoldering myeloma. And for this we planned this trial in which so patients are receiving induction with carfilzomib, lenalidomide and dexamethasone, autologous stem cell transplantation, consolidation with carfilzomib, lenalidomide and dexamethasone, and maintenance with lenalidomide and low-dose dexamethasone for up to 2 years. So patients will receive a treatment for 3 years. An important consideration, as the design of this trial was done before the publication of the new criteria for myeloma, ultra high-risk smoldering myeloma, so patients with any one or more of the biomarkers I previously said, these patients were allowed to be included in the trial. The primary objective of this trial, as I previously said, was to try to cure. And the problem is what is the definition of cure for myeloma, because we don't know and we didn't know when we designed this trial. So we consider that a surrogate marker for cure could potentially be patients achieving sustained MRD negative at 5 years after autologous stem cell transplantation. And this is what we are evaluating right now. And here you can see that all patients have been already recruited in this study. The results of this trial that you can see here in this slide were presented at the last ASH meeting, but induction was very effective with almost 50% of complete response rate. And when we evaluate the complete response rate in patients with high risk and patients with ultra high risk, you can see that there is not major differences. When we evaluate the role of transplant as well as consolidation and maintenance, you can see that the responses improved over the time. And I would say that the toxicity profile has been acceptable, and in fact, so no many patients developed significant adverse events. The primary endpoint was minimal residual disease negative sustained at 5 years. The primary endpoint, so it's impossible to be reached at that time, but you can see here, like when we selected 35 patients that had already completed the induction, transplant, and consolidation, the MRD negative rate increased from 26, 47, and 62% after consolidation. Median follow-up is very short, so it's impossible to say anything, but PFS and OS, of course, are encouraging, but we have to wait to have these results more consolidated with long-term follow-up. This is the other curative approach that it is being conducted here in the US, and the principal investigators are Brian Dury and Saji Kumar from the International Myeloma Foundation, International Myeloma Working Group, that the approach is similar to that we have done in Spain, but KRD has been combined with the monoclonal antibody daratumumab. I think that the recruitment for this study is activated right now, so I invite to all patients from the US with high-risk smoldering myeloma to be included, if possible, in this trial, in which the objective is, again, to cure some patients. This is my last slide, and in order to reply to the question, can we cure some myeloma precursor diseases, I would say that maybe it's something not relevant for MGUS due to the natural history of the disease. Smoldering is a heterogeneous disease. It is possible to identify the high-risk group of patients with smoldering. The oncology perspective supports the early treatment, and so according to my presentation, I think that we are on the way to demonstrate that early treatment in high-risk smoldering can cure some patients, but so I have to come back again some years later to say what is the end of this presentation. Thank you very much.